So today we are going to learn about the different tests based on the abnormalities of pigment metabolism and test based on the liver part. Okay, that is based on the different metabolism, because the liver is a major organ involved in the carbohydrate metabolism, amino acid metabolism, lipid metabolism. So many functions are there. Okay, for the organ liver. So we can have an idea, uh, especially okay this the different segments. So we can have one by one. The first one is the test based on abnormalities of the pigment metabolism. One second, Yeah, the test based on abnormalities of pigment metabolism. Okay, here the first one is serum bilirubin and BD-Berg reaction. Okay, this is the first test. Serum bilirubin is a major factor, and this bilirubin, you know very well, the bilirubin is classified into the total bilirubin, direct bilirubin, indirect bilirubin. So second one is the ecteric index. So that is a key parameter to identify the abnormality of the liver function. And third one is the urine bilirubin level. So urine is a excretion, okay, by the kidney, and this bilirubin, okay, if it is conjugated bilirubin, so that will be excreted by urine. Okay, there is a kidney by urine. Okay, in the way of the bilirubin is excreted. Mostly, okay, this bilirubin is a conjugated one, because unconjugated will not be excreted through urine. Okay, the next one is urine and fecal urobilinogen. We already studied in the previous one. Okay, that is urobilinogen is a substance produced by the microbial metabolism. That means the normal flora in the uh, there is gut. Okay, that means a small intestine and large intestine. It will convert the bilirubin into urobilinogen, and this urobilinogen is present in fecal sample. So this urobilinogen is partially absorbed, and some of the content of urobilinogen excreted in urine. So we are going to check both urobilinogen levels of urine and also the fecal sample. And next one is that is serum and urinary bile acids. So serum and urinary bile acids. Okay, all the five tests A, B, C, D, E. Okay, all the five comes under the test based on abnormalities of pigment metabolism. So here the pigment is, the first pigment is bilirubin, second one is urobilinogen, and the third one is bile acid. So all the five tests will be included in the first category. Coming to the second category, that the test based on the liver's part in carbohydrate metabolism. You know very well the liver is a major organ which will handle the major load of glucose. Maybe after the food intake, so all the digestive enzyme will act on the starch and all the carbohydrates, the polysaccharides, and all the polysaccharides will be hydrolyzed into monosaccharides, and these monosaccharides will be converted into glucose. Okay, this glucose will be the end product of the digestion process, and this will be mixing with the blood circulation. The hepatic circulation will take away all the absorbed carbohydrates in the form of glucose or galactose or mannose or sucrose or whatever may be, and this will be maybe taken back, okay, to the liver, and liver will convert everything into glucose. So liver will play a major part in carbohydrate metabolism. So we can check the threshold level of each and every substance. For example, here they gave only two. Okay, that is the galactose and fructose. The galactose is a substance. Okay, it is a carbohydrate, maybe derived from metabolism of carbohydrates, and this galactose can be handled by the liver to a particular extent, including galactose and fructose. So we can give the galactose sample, and we can check how the galactose is converted into glucose, and we can give the fructose sample to the patient and how the fructose levels are converted into glucose. So these two conversion process can be monitored, and that is the efficacy or the efficiency of the liver to handle the carbohydrates. So in the lab test, we can give some quantity of the normal quantity of the recommended values of galactose and fructose to the patient in the soluble form, and after a period of time, maybe 1.5 hours, we can check the levels of the galactose and fructose in the blood circulation. If the glucose levels are increased and the galactose levels are decreased, means the liver is functioning. And if the fructose level and galactose level not maybe reduced in a particular quantity, means so the liver function is decreased. Okay, that is the main problem. So the galactose and the fructose can be converted into glucose by the liver. So that is why it is the name given as a tolerance. The liver will tolerate the levels because the liver having the enzyme to convert galactose to fructose, sorry, glucose, and fructose to glucose. So we can identify, okay, that part also. Next one is third part, test based on the changes in plasma proteins. So changes in plasma protein means uh, that is very simple. That is the plasma proteins are having, okay, the different levels. That means all the plasma proteins we have to check, and the levels of plasma protein and has to be quantified between, okay, two categories, that is albumin and globulin. And albumin and globulin ratio has to be prepared and that has to be tested. So this ratio should be normal, and if the function of the liver is not normal, means the albumin levels will be decreased when compared to the globulin. So that is indication of liver pathology. So we can check the function of the liver based on the plasma protein levels. Estimation of total plasma protein. Estimation of total plasma protein, albumin, globulin, and determination of AG ratio. AG means albumin globulin ratio. So based on that, we can come to the conclusion whether the function of the liver is normal or abnormal. Okay. And next one is, I already told, the fibrinogen. All the blood clotting factors are produced by the liver. If the liver metabolism is not normal, automatically all the blood clotting parameters, including the fibrinogen, will be decreased. So we can analyze in the lab, we can quantify the plasma fibrinogen. If the fibrinogen levels are normal, the liver is functioning in a normal way, and the fibrinogen levels are decreased, means the liver's function is less. Various flocculation test. Flocculation test means the same thing. And amino acids in urine. The urine samples, what are the amino acids are excreted. Okay, that is very important because liver is a, I already told, okay, liver is a major organ, will handle so that amino acids into keto acids. The keto acids are deaminated amino acids. That is, amino group of amino acid is removed and that is combined with carbon dioxide and converted into urea. So here what will happen, the amino acid levels are same because the liver function is not normal. The amino acids concentration cannot be converted into keto acids. So if the keto acids are not formed, means the amino acid pool is increasing. The amino acid is not changed into keto acid, so there is no energy produced by TC cycle with the use of keto acids. So this may be the problem. So we have to be very careful, okay, with that. And the amino acids are the major quantifying parameter to analyze or otherwise to identify the function of liver. Okay, and next one is test based on abnormalities of lipids. That is the fourth one. Test based on abnormalities of. So this is test based on abnormalities of lipids. Lipid metabolism is also handled by liver, and the main thing is cholesterol. Okay, the determination of serum cholesterol and ester cholesterol and the ratio. Okay, ester cholesterol means cholesterol ester. Okay, and cholesterol ester ratio is very important, and based on that we can identify whether the functioning of the normal, the physiological condition of the liver is normal or abnormal. Okay, and the determination of the fecal fat. Fecal fat means the fat is not absorbed properly, and the fecal samples may have, okay, a lot of fat samples. Okay, this is why it's called as steatorrhea. Steatorrhea means more fat excretion, okay, in the form of feces. Okay, and these are all the abnormalities of lipid metabolism of liver. Okay, so this is fourth one is test based on abnormalities of lipids. Fifth one is test based on the detoxifying function of the liver. So you know that, okay, this is one of the function, major function of liver is detoxification, that is a drug metabolism. There are three metabolisms are available. Okay, one is phase 1 metabolism, phase 2 and phase 3. The third metabolism, the phase 3 metabolism, is very famous because that is pertaining on to liver, only to the liver. So the hippuric acid synthesis test, that is one of the very important tests, and amino antipyrin breath test. Okay, these are the two tests that are very important to identify or to evaluate the detoxicating capacity of the liver. Okay, the liver can be maybe visibly normal, okay, by maybe ultrasonography, but we don't know how much the function of the liver is normal or abnormal. Okay, so this can be quantifiable by using a test called as hippuric acid synthesis test, and second one is the amino antipyrin breath test. Okay, this is antipyrin, not antipyrin. And the sixth test is excretion of injected samples by liver. Okay, so that is excretory function. You know very well. Okay, excretory function means the liver is also an excretory organ like kidney. Okay, and also lungs. Lungs is also excretory function because that is excreting carbon dioxide. Okay, and that is also excreting acetone also. A person is taking fasting, and that fasting may elevate the levels of acetone and acetoacetic acid, and acetone is easily vaporizing substance, okay, that may be excreted, okay, by exhaled air. So instead of the kidney is a major one, and next to kidney, the bile is also an excretory function of liver, and another one is lungs. So pertaining to the liver, the bile is a excretion, okay, that is excretion in the form of bile, and the bile, through the bile, okay, some of the substances may be excreted. Okay, here there are two tests are there. Okay, one is bromo sulfurylation test. Okay, bromo sulfurylation test, that is BSP retention test, and I31 rose Bengal test. So these two are a little complicated, and usually it is not done, okay, in the routine clinical biochemistry testing and all. And if it is needed, for example, the excretory function is, if it is needed, okay, that may be carried out in the clinical laboratory. And next one is seventh test, formation of prothrombin by liver. That is, I already told that, okay, this is a blood clotting parameter. There is a prothrombin, thrombin, and everything. Okay, so the formation of prothrombin by liver. So this can be assessed by or determined by the prothrombin time. Okay, so prothrombin time is the determination of blood clotting parameter, and the time is very important, and based on the time we can identify whether the blood clotting factors are in the normal concentration or not. So next, coming to the eighth test based on amino acid catabolism. We already studied about amino acid catabolism because amino acid catabolism means a breakdown of amino acids. You know, the breakdown of amino acid, just now I said, if the function of the liver is good, means the NH3 group removed from amino acid, and after NH3 removal from the amino acid, it is called as keto acid. These keto acids will be transported into the blood circulation, and it will go to the each and every part of the cell, because each and every part of the cell, the TCA cycle is there, and the TCA cycle, all the metabolites of TCA cycles are keto acids. For example, starting from citrate, cis-aconitate, isocitrate, alpha ketoglutarate, succinyl CoA, succinate, fumarate, and malate. So all are the derivatives of keto acids. You know very well the keto acid, the Krebs cycle. So this removal of ammonia is very important. If the removal of ammonia is not done, the amino acid pool is increased. So previously we had a test for estimation of amino acids. Now this is not amino acid estimation. How much amount of NH3 is liberated in the blood sample? So this quantity can be assessed, okay, by the NH3 estimation, that is the estimation of ammonia, okay, so in the blood sample. So this is a very important test, that is the toxicity, ammonia toxicity can be evaluated by using this test. Next one is a determination of glutamine in CS fluid. CS means cerebrospinal fluid. So this is indirect liver function test. Not because we are not going to get the blood sample. So here we are going to check, get the aspiration, okay, from the cerebrospinal fluid, and from that, okay, we have to check the glutamine concentration. So why we have to check the glutamine concentration? So glutamic acid attached with the amino group, it's called as glutamine. Glutamic acid is a normal amino acid. Okay, we already studied about glutamic acid, aspartic acid, and glutamic acid, that is acidic group containing amino acids. So this glutamic acid, if it is receiving one NH3 by the deamination enzyme, you already studied about ALT and AST, aspartate aminotransferase and alanine aminotransferase. All these aminotransferases transfer the NH3 group from amino acid, and these NH3 is attached with glutamic acid, and the glutamic acid is converted into glutamine. So this is the formation of glutamine. So this glutamine can be evaluated, okay, in the CS, because the retention time of glutamine is more in CS when compared to any other fluid in the body. So that is why the CS is taken. That this is a very complicated test. Only with the experienced practitioners, okay, we can do this one. It is not really needed, and we can check only the NH3 of blood. And the last test is the determination of serum enzyme activities. We already studied about all the enzymes of liver. So what are the enzymes? ALT, AST, GGT and ALP. This is alkaline phosphatase. So all the enzymes can be evaluated, okay, in the serum, and so based on the activity of all the enzymes, we can identify what is the pathological status of the liver. So with this, all the tests are going to be completed. All the 10 tests. Okay, these are the tests based on abnormality of pigment metabolism. Second one is carbohydrate metabolism. Third one is plasma protein, and fourth one is abnormalities of lipids, and fifth one is the detoxification, that is the drug metabolism related test, and the sixth one is excretion of injected substances, that is excretory function. Okay, that is a bile test and bile function test, and the next one is prothrombin, that's blood clotting factor test, and amino acid catabolism, and finally all the serum enzyme activities related to the enzymes of liver. So with this we can conclude all the tests, and we can go to the enzyme assay. Just now, okay, in the 10th one is determination of serum enzymes. So in the serum enzymes, we already studied in detail, okay, of all the enzymes in the previous class. And again, we can have a clarity here. Enzyme assays as per the priorities useful in detecting the alterations in the liver diseases. For example, here, you can see here, yeah, this hepatocellular damage or increased permeability of the liver cells. So these are the alterations detected, and the indicator enzymes are transaminases, all the transaminases, and the old name is SGOT and SGPT. The new one is, you have to use only the new name ALT and AST. Okay, and next enzyme is ornithine carbamoyl transferase, and sorbitol dehydrogenase, and all the three enzymes responsible for hepatocellular damage or increased permeability of liver cells. Hepatocellular damage means the hepatocytes or the liver cells, either damage of hepatocytes and increased permeability. Some of the parameters like the viral infection may increase the permeability of liver cells, the hepatocytes. So these can be evaluated by using the three enzyme estimation, known as transaminase, all the two different types of transaminases, SGOT, SGPT or ALT and AST. Okay, and the next one is ornithine carbamoyl transferase or ornithine transcarbamylase, both are same, and sorbitol dehydrogenase. All the three enzymes are responsible, and we can use these three enzyme estimations based on the activity of the enzymes. We can come to the conclusion whether the hepatocytes are damaged or increased permeability of the liver happened. So next category is B is extrahepatic or intrahepatic obstruction. Extrahepatic means outside of liver. Intrahepatic means within the liver. Obstruction means blocking. Okay. So extrahepatic means next to the liver. Okay, that is liver is having collecting tubule. Okay, that is the bile collection, and the bile collection is connected with the gallbladder, and from the gallbladder, this goes and joining with the duodenum. So this is called as extrahepatic. Intrahepatic means within the liver, the canaliculi. Okay, canaliculi means, okay, the collecting tubules are there. So within the collecting tubules, any crystals are formed, or any stone is formed, the bile stones that may be obstructing a particular region of the particular duct. So this will be either benign or malignant, either by obstruction by crystal formation, or otherwise stone formation, or otherwise the benign or malignant tumors. So that is benign means there is no complication, and so there is intact. Okay, there is no further growth. It is a benign means, okay, this non proliferative stage of cancer. Malignant means it is fastly dividing. Okay, these are the two different types of cancer also. For this, we can use alkaline phosphatase enzyme and 5' nucleotidase and gamma glutamyl transferase and LAP, and so these all these, okay, three enzymes, okay, that is alkaline phosphatase, 5' nucleotidase and gamma glutamyl transferase and LAP. Okay, so all the four enzymes are responsible for the determination of this function. This is alteration detector. Next, coming to the protein synthesis, because I already told the protein synthesis, that means albumin production is a major function of liver. Albumin is very important parameter, so that is a carrier protein for many of the metabolites, or many of the primary metabolites and many of the secondary metabolites also. Okay, and here the pseudocholinesterase means there are two cholinesterases are there: acetylcholinesterase and butyrylcholinesterase. You know very well, at the time of studying the nervous system and the human physiology, you may be studied the synaptic transmission, that means signal transduction, okay, in the nerve. So in the nerve cells, okay, the two nerve cells are there. One is a preplate and postplate. These two nerve end, okay, this is one nerve ends with the preplate and another one is the postplate. These two will communicate, okay, by an substance called as that is acetylcholine. Okay, it is a neurotransmitter. So this neurotransmitter will link the connections. That means one cell will liberate acetylcholine uh, with the preplate and the postplate having the receptors. The receptor will get that acetylcholine and again induces the activity of signal transmission. Apart from that, acetylcholinesterase having the major function in cholinergic tissues and also cholinergic system. Okay, and we have the system, okay, in the nerve function, that is sympathetic nervous system and parasympathetic nervous system. Okay, I think you already studied, okay, this one in the nerve function and nervous system in the human physiology. So here the difference is acetylcholinesterase, we know that is involved in the signal transduction in the nerve cells, but pseudocholinesterase, it is pseudo means it is not a actual cholinesterase involved in the signal transduction. Another cholinesterase is there, that is pseudo means it is mimicking the function of liver, the function of cholinesterase, but it is not doing the function of acetylcholine to acetate and choline. Okay, the acetylcholinesterase enzyme, it is present in the post plate of all the nerve cells, and after binding of acetylcholine to the acetylcholine receptors, so that one is liberated from the post plate, and immediately after the liberation, this acetylcholinesterase enzyme is a membrane bound enzyme that will cleave acetylcholine into acetate and choline. So that is a normal function. Okay, pseudocholinesterase is an enzyme, okay, that is called as a butyrylcholinesterase, and there is no clear function till date. So that may be one of the parameter to evaluate protein synthesis. Okay, so this is very sensitive test, and we can identify whether the function of liver by means of protein synthesis is perfect or not. The last category, alcohol abuse. Alcohol abuse means, I already told in the previous class, over consumption of alcohol. So somebody addicted to take alcohol means the gamma glutamyl transferase, okay, GGT. So this one is increased. So we can evaluate GT, okay, there is gamma glutamyl transferase of serum, and based on the levels of increased levels of GGT, we can come to the conclusion the liver is damaged only because of alcohol or not. Okay, this is very common test, okay, in the clinical lab. And so with this, we can conclude all the enzymes assay as per the priorities useful in detecting the alteration in the liver samples. So there are four alterations. One is hepatocellular damage, and next one is extrahepatic intrahepatic obstruction, and third is protein synthesis, and the fourth one is alcohol abuse. So next one is organ function test. We already completed, okay, this test, but again, okay, I want to refresh this one as a consolidated chart. Okay, we already completed this one. Okay, no need to worry about this because this is a big chart, and I will zoom. Okay, this one. Yes. organ function test. The first one is differentiation of three types of jaundice. So we have three different types of jaundice. One is hemolytic jaundice, okay, that is pre-hepatic jaundice, and hepatic means that is the pertaining to the liver. So liver is the affected organ, and obstructive or post-hepatic jaundice. Okay, so we categorized into jaundice into three different types, that is hemolytic or prehepatic jaundice, and hepatic or parenchymatous. Parenchymatous means a liver cell damage related jaundice. Parenchymatous jaundice and obstructive or post-hepatic jaundice. Okay, so with this we can categorize into three different types. Number one, the causes. Why this the first type, hemolytic or prehepatic jaundice, is happened? So due to the excessive hemolysis. Why excessive hemolysis happen? There is the defects in RBC and intrinsic causes of external to the RBC. So disease of parenchymal cells. Second one is the hepatic disease of parenchymal cells and liver. Example: viral hepatitis, toxic jaundice. This is due to drug toxicity, and cirrhosis of liver and fibrosis. And due to obstruction of the biliary passage and extrahepatic gallstones, tumors, and enlarged lymph nodes, and etc. And intrahepatic cholestasis. So all the three are covered, okay, in this category. And maybe the second one is the clinical findings. So second case is clinical findings, the degree of the jaundice. Usually the first one, usually the low chance of getting the first type of hemolytic jaundice, the clinical findings. And second category is marked jaundice, okay, with the 2 plus to 3 plus, that is medium to very high. Okay, this medium to moderate to high levels of possibility. Okay, and the third one is that is also same thing, okay, when compared to the hepatic, the obstructive also medium to excessive. And the feces, dark colored feces, okay, here in the hemolytic jaundice, and variable usually pale feces, okay, in the hepatic jaundice, and clay colored, okay, that is okay, the clay colored means, okay, for the obstructive one. Why it is clay colored? Because that is having the obstructive, so that is increasing the that is conjugated bilirubin levels. So that is why it is clay colored. Next, coming to the biochemical findings. So this is the clinical findings, that is the physical identification. Okay, the degree of jaundice is less, and here mild to moderate to severe, and moderate to severe. Okay, this case. Okay, and the next, coming to the biochemical findings of jaundice. So here we can identify the based on the bile pigment metabolism. So that is a VD-Berg reaction. So this may be indirect and may be delayed or positive, biphasic and direct. Type of bile pigment in circulation. So usually the first type, okay, that is a hemolytic jaundice. Unconjugated bilirubin is circulated more. Second one is hepatic jaundice. A mixture of conjugated and unconjugated will be there. And third one is the conjugated will be more. Okay. So this is the identification. So here the third one is obstructive, conjugated only increased, and hepatic jaundice, only the mixture of conjugated and unconjugated are increased. Here the first case, okay, the hemolytic jaundice, unconjugated only increased. So this is the one, okay, already studied in the previous class. I think you remember, okay, this one. Next one is serum bilirubin. So if you are comparing all the bilirubin into three different types of jaundice, usually low bilirubin concentration, 3 to 5 milligrams per deciliter, and maybe high up to 20 milligram percentage, okay, that is deciliter, and very high concentration, that is more than 25, that is up to 50. Okay, this is the major difference. We can, based on the serum bilirubin, we can identify. So what is the type of jaundice? So here this is evident. You can see here the first one is, so this first column is usually low. That means this is for hemolytic jaundice. Second one is hepatic jaundice, and third one is the obstructive jaundice. The first one is 3 to 5 milligram, and second one is 20 milligram, and third one is 50 milligram. It's entirely the very different in the range. Okay, we can identify very easily. As a biochemist, okay, if you are doing only the serum bilirubin, only with the number of the total bilirubin you can identify what is the type of jaundice. Simple. Okay, the bile pigments in urine. Okay, next category, we have the pigments bilirubin and urobilinogen, fecal stercobilin. Okay, so it is not detected in the first case and present maybe, so the present, okay, that is in the second category, and the present with the 2 plus, that means present with more concentration. Which one? The bilirubin. The first case, bilirubin is not present in urine in the first case, that is hemolytic jaundice or prehepatic jaundice. Second case, it is present, means the traces of bilirubin is present. And third case, obstructive jaundice, we have present 2 plus, means more concentration of bilirubin is present. Okay, and next one is urobilinogen. So here it is increased, maybe increased or normal, and the third one is decreased or absent. You can see here the urobilinogen is very high here. If it is very high, we can come to the conclusion, so that is a hemolytic jaundice. Second one, present or maybe increased. So it is not a clear cut, okay, the definitive test. Okay, maybe increased plus or normal level. Okay, and third one is decreased or absent. So if you find a person with urobilinogen in urine very high levels, this is the indicator. That means hemolytic jaundice. Third type is fecal stercobilin. So fecal stercobilin is increased levels of, very high levels of stercobilin in the feces. Okay, that is in the first type, and second one is decreased, and third type is decreased or absent. So this is also an indicative measure. And the third one is steatorrhea. Steatorrhea means, you know very well, the steatorrhea is the excretion of excessive fat in the feces. Okay, that is usually not present in the first case, and the second case and third case it is present. Okay, and the biochemical, other biochemical features. Now we are going to the biochemical test. The first one is PT, prothrombin time. And the first one is normal, second one is increased, and the third one is increased after parental vitamin K becomes normal. You can see here the first case, if the bilirubin levels are very high, at the same time, okay, urobilinogen is also very high in the urine, and if it is normal means, so that is hemolytic. Very confirmative test. Okay, and here is also increased and there also increased. So there is no much difference to differentiate the hepatic jaundice and also obstructive jaundice. Third one is the turbidity and the flocculation test. So coming to the turbidity, yeah. So coming to the turbidity and flocculation test, the thymol turbidity test. Okay, this is negative for the obstructive jaundice. Sorry, the first one hemolytic jaundice, and the second type and third type. Second type is positive, so it is major positive. That means 2 plus or 3 plus, and third test is also negative. And thymol turbidity test, if it is giving the positive result, means okay, that is hepatic parenchymatous jaundice. Okay, and Jirgis flocculation test, okay, that is negative for hemolytic, and second one is mild positive, that is a 1 plus, okay, for hepatic jaundice, and third one is obstructive jaundice 2 plus to 3 plus, very high or excessive levels. Coming to the enzymes, okay, these are enzymes are very sensitive one. With this we can conclude, okay, all the parameters. Okay, the first one is aminotransferase activity. In the aminotransferase, ALT, okay, is very important. I already told why we are very specific to ALT, means because AST is not only to liver, okay, that may be expressed in some other organs also. Okay, that is why ALT, that is SGPT. Usually normal in the first case, you can see here, usually normal in the first case, and the second case 3 plus to 4 plus, and third case only 2 plus. Okay, so this is the clear indication. And if it is ALT is normal, that is hemolytic. If it is increased, this may be possible for both cases, that is hepatic and also obstructive jaundice. So coming to the next test in the enzymes, alkaline phosphatase, it's quite normal, okay, in the first one, that is hemolytic jaundice. And you can see here the increased slightly, okay, that is plus, only 1 plus, and usually less than 30 K. K units means, so this 30 K is maybe that is a level, or that is a single plus level. Okay, and if it is exceeding 30 Ka means that is the third one. So marked increase 30 to 100 KAU. Okay, that is a unit representing the levels of alkaline phosphatase. Okay, and you know very well, okay, this IU level is very important, the international unit of enzyme activity. So here this is representing with the KAU. Okay, so that KAU level, if it is less than 30, that is hepatic jaundice. If it is 30 to 100, that is, or more than 35, okay, that suggests obstructive jaundice. Okay, it's very simple. With that alkaline phosphatase, we can identify whether it is hemolytic jaundice or obstructive jaundice or hepatic jaundice. Okay. Third, of enzyme, and the final test is for enzymatic analysis. The 5' nucleotidase. Okay, 5' nucleotidase, it is quite normal in the first case. Okay, that is hemolytic jaundice, and in slightly increased, and there is a steep increase in the third case. The second case is hepatic jaundice or parenchymatous jaundice, and third one is obstructive jaundice. So in the both cases, okay, this marked increase here also and also here. So here it is quite normal. Okay, so with this, so this is a complete organ function test. The differentiation between three different types of jaundice. You can see here all the three different types of jaundice. This is hemolytic or prehepatic jaundice, the first column, and second one is hepatic or parenchymatous jaundice, and third one is obstructive jaundice or post-hepatic jaundice. So both are same. In the examination, if they're asking the question hemolytic jaundice, okay, or prehepatic jaundice, you have to answer both. Okay, and both are same, hepatic or parenchymatous jaundice or obstructive or post-hepatic jaundice. So this table is very important to identify what is the type of jaundice, to categorize the different types of jaundice also. Okay, with this we can conclude all the organ function test of liver, and next we can compare the levels of LFT. So this LFT levels can be compared, okay, very easily, and you can see here. So this animation video, okay, I will show it to you. The comparison of LFT elevation due to the different etiologies. Okay, and this is normal level is approximately 30 to 40, and chronic viral hepatitis, that may be slightly increasing. Steatohepatitis also slightly increasing, and third one is alcoholic hepatitis. AST range is increasing more, and HELP syndrome, that is also increasing much more. Drug toxicity, extreme levels of LFT elevation, and next one is acute viral hepatitis, initially less and subsequently that is increased more, and ischemic hepatitis without any symptoms, okay, that may come, okay, that is increased more. Acetaminophen and overdose, that is also there. So I'll play this video including this audio also. I'll explain, okay, by stopping in between. So this video will give the clear picture about the interpretation of liver function test.
This is Eric from Stanford, and today I'm going to be discussing everything you will ever need to know about liver function tests, what they are, and an overview of how to interpret them. The specific learning objectives are first to list the tests commonly included under the heading of liver function tests, more commonly known as LFTs. Second, to explain the basic normal physiology of each of these molecules. Next, to list the common etiologies for specific LFT abnormalities. And last, to recognize common patterns of multiple LFT abnormalities which suggest specific diagnoses. So what exactly are LFTs? They are a commonly ordered panel of blood tests which, as you might guess, evaluate liver function. However, they evaluate much more than that. They also look at liver damage and at the integrity and function of the entire biliary system, including the intrahepatic and extrahepatic bile ducts and gallbladder.
So with this, one more thing is there, that is liver function.
And LFTs evaluate
liver damage and
aspects of physiology outside of the hepatobiliary system altogether. For example, they provide some insight into coagulation, hemolysis, nutrition, and bone turnover, among many other conditions.
So these are the additional parameters also there. Okay, that is you can see here the coagulation, hemolysis, nutrition, bone turnover. So all the parameters will play a role on the liver function, and this may interfere with LFT test also. That is the liver function test. Coagulation is a major factor. I already told that, okay, this all the blood clotting parameters are produced by the liver, and hemolysis will play a major role, okay, in the assessment of the liver function test. And nutrition, the nutrition of the person, and the fourth one is bone turnover. So LFTs are used, the liver function test. LFT is nothing, okay, the liver function test is commonly used, okay, to evaluate the liver function, the first one, and liver damage, okay, to evaluate the how much amount of liver is damaged, and what is the level of intensity of damage, that also we can assess. And the last one is biliary system function, okay, whether the biliary system is functioning normally and the bile is excreted to duodenum or not. Okay, so with this we can go to the next slide with more information.
The specific tests included under the general heading of LFTs are hepatic enzymes, tests of synthetic function, and bilirubin. In common practice, there are four hepatic enzymes of interest: aspartate aminotransferase, abbreviated AST, alanine aminotransferase, or ALT, alkaline phosphatase, which is commonly informally abbreviated ALKPHOS, and gamma glutamyl transpeptidase, abbreviated GGT. AST and ALT are collectively known as the aminotransferases. In addition to these four enzymes, the literature also frequently discusses the diagnostic use of 5-nucleotidase. However, I've never seen it ordered once, so won't discuss it further here. Tests of synthetic function, that is how well the liver can synthesize new compounds, particularly proteins, include serum albumin and something called the International Normalized Ratio, or INR. And last, bilirubin is subdivided into unconjugated bilirubin, also known as indirect bilirubin, and conjugated or direct bilirubin. Although the indirect and direct terminology is still used in some textbooks and labs, it is based on an outdated lab assay technique and has nothing to do with physiology.
Okay, these LFTs may be used for assessing the hepatic by the use of hepatic enzymes and synthetic function test and the bilirubin levels. All the three are very important. We already studied about the different aminotransferases. Okay, one is aspartate aminotransferase, alanine aminotransferase, and alkaline phosphatase and gamma glutamyl transferase. Okay, and synthetic function tests like albumin and INR. INR ratio is blood clotting factor. Okay, that is the international normalized ratio of blood clotting, and that is called as INR number. Okay, that is very important. Maybe if a person going for surgery, so they will evaluate, the doctors, they will evaluate the INR number. If the INR number is normal only, they will do the surgery, or otherwise if it is abnormal, they will not do it. That may be lethal, or sometimes that may lead to the death of the person. Okay, because there is no blood clotting maybe during the surgery or after the surgery. So all these parameters are very important. Just blood clotting factors play a major role in any emergency condition. For example, any trauma or any accident or any cut or something. Clear? And the last one is bilirubin level. We already studied about in depth about bilirubin, what is the metabolism and what are the different types, and total, conjugated and unconjugated. That is indirect and direct bilirubin. Okay. So indirect means unconjugated bilirubin. Direct means conjugated. You can remember that direct means that is available one. Direct means, so it is direct, maybe that is it is available in the serum. That means if it is available serum is a direct means it is attached with diglucuronide. Okay, that is conjugated. Indirect means it is available but it is attached with albumin. So that is why it is unconjugated, because bilirubin is attached with albumin. So that is why it is indirect unconjugated. Okay, all the parameters going to be studied in addition to the enzymes. Okay, all the four, one more enzyme is also there, okay, for the diagnosis, and that is not very commonly used in the diagnostic labs. Okay, that is 5-nucleotidase. Okay, this enzyme is very important. At the same time, okay, the diagnosis or estimation of this enzyme is more tedious and time consuming. So that is why not much focus, okay, here in the diagnostic industry, practically speaking. Okay.
I'll therefore refer to these as unconjugated and conjugated bilirubin for the remainder of the video. Now, when most people use the term LFTs in the clinic or on the wards, they're usually referring to a specific preset panel of blood tests, all drawn off the same tube. The two tests not included in the standard LFT panel, at least not in the US, include the GGT and the INR. It makes sense not to include the INR since it needs to be drawn into a different type of specimen tube. However, it seems illogical to me that the GGT is not included. If labs are trying to save money by preventing redundancy, it would seem to be more logical to include the GGT and not ALK-Phos, and make ALK-Phos a standalone test. Hopefully, by the end of the video, you'll understand why. In addition, there are several variations on how bilirubin is reported on an LFT panel. Uncommonly, although it would make the most sense, is it reported separately as unconjugated and conjugated. Instead, it is usually reported as conjugated and total bilirubin, or sometimes just total bilirubin. I'm going to now discuss these labs either one at a time or in pairs, including both the normal physiology of each and etiologies of potential derangements. First up are AST and ALT. AST and ALT are two examples of transaminases which catalyze a reaction between a keto acid and an amino acid in which the ketone and amine groups are exchanged. AST is found throughout the body, particularly in the liver, heart, muscle, kidney, and red blood cells, while ALT is found predominantly in just the liver. Therefore, increases in ALT are more specific than AST for pathology of the liver and biliary system. Looking at the specific list of etiologies of increases in AST and ALT can be seen in any form of hepatocellular disease, such as cirrhosis, hepatitis, drug toxicity, fatty liver, also known as steatohepatitis, and venous congestion from CHF, also known as congestive hepatopathy. It can also be seen in any form of biliary disease, such as cholelocholelithiasis, cholecystitis, cholangitis, and cholangiocarcinoma, basically any disease that starts with the syllables chole. Often, diseases of the biliary system are collectively called cholestatic disease, a term which serves as a parallel to hepatocellular. In addition to hepatobiliary disease, which is the umbrella term for both hepatocellular and cholestatic disease, AST is also elevated in rhabdomyolysis, which is muscle breakdown, acute myocardial infarction, and hemolysis, though the elevation in the last entry is typically only modest. As previously stated, the etiology...
Yeah, these are all the indications of AST. This AST is aspartate aminotransferase. This is elevated in any form of hepatocellular disease, that is cirrhosis, hepatitis. We already studied about acute hepatitis and chronic hepatitis, or any drug toxicity, etc., or any form of biliary disease, that is cholestasis. Okay, cholestasis. Any word okay starts with cholestas. Choles means okay that is related to bile. Okay. Cholangiocarcinoma, okay, that is cholangiocarcinoma means the bile duct cancer, and rhabdomyolysis and acute MI, myocardial infarction. Acute myocardial infarction means heart attack, also later it's AST, and hemolysis. And apart from that, one more aminotransferase is there, okay, that is discussed here, that is ALT.
of an increase in ALT are limited to hepatocellular and biliary disease only. Occasionally, you may hear people informally refer to an increase in AST and ALT in the absence of other overt signs of liver disease as a transaminitis, a term I personally don't like since it...
ALT is very specific to the hepatocellular disease. That is why our focus to get the status of liver, the normal physiological status of liver, can be analyzed by using only ALT. AST is not much focused. So any form of biliary disease or otherwise any form of hepatocellular disease, ALT levels are increased. We already told the biliary disease can be differentiated with the hepatocellular disease by GGT. So this gamma glutamyl transfer is very specific to maybe all the problems related to bile or bile duct or obstruction or something. Okay. Right.
Its suffix implies the presence of inflammation, which may not actually be there. Let's take a look at how elevations in AST and ALT compare to one another in different disease states. ALT is usually greater than AST in most chronic liver disease that is not caused by alcohol, unless cirrhosis develops, at which point AST becomes typically greater than ALT. I don't know of a specific study in which relative increases in AST versus ALT are used to screen for when a patient with chronic hepatitis has developed cirrhosis, but to me it seems to be potentially something to look for. And the AST to ALT ratio above 2 in a patient with probable liver disease is strongly suggestive of alcohol as an etiology. The explanation as to why this happens is a little complex and beyond the scope of this video. An AST to ALT ratio above 5 is suggestive of an extrahepatic source of AST, such as rhabdomyolysis or an acute MI.
So all the three parameters we already discussed, and the ALT AST ratio, what is the difference, and in the hepatitis we covered all these. Okay, and the ALT and the AST, and what is the ratio, 3 times of or 5 times of. So everything is completed there. Just you can follow that formula within the box. That is more than enough. Okay, right.
Among patients with LFT increases due to liver disease, we can use the degree of elevation in formulating a differential diagnosis, since certain diseases result in a stereotypical range of LFT elevation. The normal range of AST and ALT differs a little bit between different labs and depending on gender, but as a general rule, the AST and ALT should both be below 40 units per liter. Some sources advocate for a lower limit than this. In chronic hepatitis B or C infection, or with steatohepatitis, the transaminases can be near normal or even normal, and are usually not above about 200 to 300 units per liter. In alcoholic hepatitis, the AST typically ranges from about 100 to 500, with ALT about one half of that. In the HELP syndrome, which is a life-threatening complication of pregnancy, the transaminases are usually above 70 and can range into the high hundreds. Increases from drug toxicity, depending upon the exact situation, can be anything from barely noticeable to an AST and ALT in the thousands. And then acute viral hepatitis, ischemic hepatitis, known colloquially as shock liver, and acetaminophen overdose, all can result in transaminases ranging from the mid-hundreds to the many thousands. Let me move on to discuss ALK-Phos and GGT. Although the latter is not included in the standard LFT panel, ALK-Phos and GGT act like a pair in an analogous way to AST and ALT. Alkaline phosphatase is actually a collection of isoenzymes present throughout the body. The most clinically relevant forms of ALK-Phos are found in the liver, bone, white blood cells, small bowel, and placenta, but its exact physiologic purposes in these sites are not known. Normal ALK-Phos levels vary greatly depending on age and gender, and even depend upon blood type. And unfortunately, although ALK-Phos exists as different isoenzymes, with different forms coming from different organs, there is no reliable means of testing for individual isoenzymatic forms. Because of this problem, we need the GGT. Gamma-glutamyl transpeptidase catalyzes the transfer of a gamma-glutamyl group from the glutathione to an amino acid, peptide, or water as part of the rarely discussed gamma-glutamyl cycle. GGT is also increased in a broad range of hepatobiliary diseases with similar sensitivity and specificity as ALK-Phos. However, GGT is not present in bone in significant amounts. So let's compare the etiology of increased alkaline phosphatase and GGT. The most important general etiology of a high ALK-Phos is any form of biliary pathology. Next, any form of hepatocellular disease, though elevations from hepatocellular disease on the whole are less dramatic than those from biliary disease. Then any cause of high bone turnover or bone loss, such as bone metastases, Paget's disease of bone, hyperthyroidism, or hyperparathyroidism. And the last major cause of a high ALK-Phos is normal pregnancy, where elevations tend to be more modest than in the above three categories. Let's compare that to causes of an elevated GGT. So we have any form of biliary disease or hepatocellular disease, but instead of bone problems, there is alcohol abuse. Also, although I have never seen a situation in which this becomes relevant, diabetes, phenetone use, and renal failure.
You can see the differences between alkaline phosphatase and GGT. So any form of biliary pathology, and this is not very specific to the liver, and alkaline phosphatase, and comparing with the GGT is always better when compared to alkaline phosphatase, because in the previous slide, okay, it is not very specific, and due to age, alkaline phosphate levels may vary from person to person, and it is not reliable at all. So that is why maybe based on the WHO norms, the GGT is more reliable, because any form of biliary system disease, the GGT levels are increased, and any form of hepatocellular disease, the GGT is increased, including alcohol abuse, diabetes, diabetic ketopathy, and phenytoin, that is anti-convulsant drugs, okay, maybe usage of anti-convulsant drugs, and renal failure. Okay, these are all the parameters possible for increase of GGT. So GGT is more preferable when compared to alkaline phosphatase.
Are all also reported to be associated with mildly elevated GGT levels. Here's a chart incorporating all the diagnostically relevant info about ALK-Phos and GGT. In situations in which the ALK-Phos is mildly or moderately elevated and the GGT is elevated, consider either hepatic or biliary disease. If the ALK-Phos is severely elevated and the GGT is elevated, consider biliary disease only. If only the ALK-Phos is elevated, the problem is likely in the bones. Finally, if only GGT is elevated, consider the possibility of alcohol abuse.
Here, the comparison is done, okay, with alkaline phosphatase and GGT. So based on the diagnostic consideration, that means the first one is hepatic or biliary disease. Okay, GGT is elevated much, and there is a comparison between GGT and alkaline phosphatase. It is a mild or moderately elevated. So which one is more prominent? Okay, that is GGT is very specific to hepatic and biliary disease. In second case is biliary disease only, that is which one is elevated, severely elevated is alkaline phosphatase, and elevated is GGT. And the bone disease only elevated in alkaline phosphatase, and GGT is nearly normal. And alcohol abuse, alkaline phosphatase is nearly normal, and the elevated levels of GGT is there. So this is a very significant one, okay, to identify what.
Well, there really isn't a such thing as a pathologically low AST, ALT, or GGT. There are a small handful of random conditions that are associated with a low alkaline phosphatase level. For example, hypothyroidism, pernicious anemia, and zinc deficiency. And one really interesting association is an extremely low ALK-Phos level seen in Wilson's disease, which appears to be best described in patients presenting with a combination of fulminant hepatic failure and hemolytic anemia. I've personally encountered such a case once in residency, in which the patient, a 20-year-old woman, had an undetectable ALK-Phos level. Had I not discounted it as some quirky lab artifact, it would have suggested the diagnosis much more quickly than the standard workup did, which took about 2 days. I'll now move on to tests of synthetic function. Albumin is a globular protein produced solely by the liver and comprises about half of the total protein in the blood. Albumin is negatively charged at physiologic pH, and therefore it binds to cations such as calcium, sodium, and potassium, along with some hormones, conjugated bilirubin, and some medications. The primary function of albumin: to maintain capillary oncotic pressure. Here is the Starling equation, which mathematically describes the balance between fluid moving between the capillary or intravascular space with the interstitial space. Don't worry, I'm not going to discuss the details of this equation, but I just wanted to point out that albumin affects this value here, the capillary oncotic pressure. The greater the difference between the capillary and interstitial oncotic pressures, the more fluid will stay in the intravascular space and not leak out of the capillaries. There are 3 major categories of the etiologies of a low albumin. There can be decreased synthesis, as in chronic liver disease and malnutrition, increased loss, as in the nephrotic syndrome and the relatively uncommon condition of protein-losing enteropathy, and internal redistribution, as in increased capillary permeability, which might occur in the setting of severe sepsis. The consequence of a low albumin is related to fluid leaking into the interstitial space. So in the legs, we would see pitting edema, in which firm pressure applied to the subcutaneous tissue leaves an impression. And in the abdomen, it can contribute to the development of ascites, which is fluid accumulation in the peritoneal cavity. The next test of synthetic function is the INR. The INR is actually based on something called the prothrombin time, abbreviated PT, which is a measure of the extrinsic pathway of clotting, which is dependent upon clotting factors produced by the liver. If you're not familiar with the clotting cascade, don't worry, just remember that the higher the PT and the higher the INR, the less your blood is able to clot in response to trauma. The PT is a functional test that varies significantly between different labs. Therefore, a calculation called the International Normalized Ratio, or INR, was created which normalizes the PT so that values between different labs can be compared. Etiologies of an elevated INR are primarily related to a decreased synthesis of clotting factors. This can be due to chronic liver disease, as the liver is responsible for producing these. It can also be due to vitamin K deficiency, since their synthesis is vitamin K dependent. Causes of vitamin K deficiency include general malnutrition, fat malabsorption, and prolonged use of broad-spectrum antibiotics, as these can kill normal gut flora responsible for producing vitamin K. In addition, anticoagulants, specifically Coumadin and Argatroban, can affect the INR.
Hello, sir.
Yes.
And finally, in addition to decreased synthesis of clotting factors, an increased consumption of clotting factors, as seen in DIC, can also lead to a high INR. As expected, the primary consequence of a high INR is a generalized increased risk of bleeding, which can occur in the GI or GU tracts, or in the soft tissue, including retroperitoneal space. Here's a picture of a patient with a massive flank ecchymosis from a spontaneous retroperitoneal hemorrhage. The final test to discuss is bilirubin.
Yeah, with this INR, okay, we can stop this lecture.